Welcome to Rootkeep. Autumn 1918. The deadliest pandemic in recorded history. 10,000 Americans dying every week. Two groups of physicians treated comparable influenza cases and had sharply different outcomes. Conventional doctors lost 3 patients per 100. Eclectic physicians lost 6 per 1,000. The better results came not from aspirin, the new pharmaceutical wonder drug, but from boneset, a wetland plant. Within 20 years, no licensed physician in America would be trained to use it. And the report that helped bury it was written by a man who never held a medical degree. This story starts long before any pandemic, in the wetland meadows of the 1600s on the eastern seaboard, where Haudenosaunee, Cherokee, Mohegan, Menominee, and Delaware healers were already harvesting a tall perennial with clasping leaves and white flower clusters, using it to break the deadliest fevers they knew. In the wetlands and meadows stretching from Nova Scotia to Florida, a perennial with rough, lance-shaped leaves and flat-topped white flowers grew in abundance. Known to botanists as Eupatorium perfoliatum, this plant stood out for its distinctive pairs of leaves that fused around the stem, giving the appearance that the stalk pierced directly through the leaf. Among the Haudenosaunee, Cherokee, Mohegan, Menominee, and Delaware nations, boneset was not just a feature of the landscape, it was a cornerstone of medicine. For generations before European contact, tribal healers prepared infusions of boneset's leaves and roots to treat fevers, chills, and respiratory distress. Cherokee records describe its use as a febrifuge and diaphoretic, brewed to break the grip of fever through heavy sweating. Delaware healers relied on root decoctions for chills and fever, while the Iroquois combined it in compound remedies for coughs and as washes for skin conditions. Mohegan and Menominee traditions add diuretic and tonic uses, with the plant sometimes given to induce vomiting in severe illness. These practices, documented in 69 separate entries in the Native American Ethnobotany database, reflect a sophisticated clinical understanding. Boneset was chosen for its observable effects on the body's heat, sweat, and pain. The plant's ecological range mirrored the reach of mosquito-borne fevers and epidemic chills, making it a vital tool wherever such illnesses struck. Early colonial observers, including William Bartram in the 1790s, noted the reliance of native healers on this fever plant, and frontier doctors soon adopted the remedy, crediting indigenous expertise. The name boneset entered English not as a botanical curiosity, but as a clinical term, settling the bones of a fever, relieving the deep aches that define influenza and breakbone fevers. In this way, boneset's reputation was established not by laboratory theory, but by generations of clinical observation and collective experience. Subscribe for more evidence-led investigations into the hidden roots of medicine. By the mid-19th century, boneset had moved from indigenous hands into the heart of American medical institutions. Nowhere was this more evident than at the eclectic Medical Institute of Cincinnati. Chartered in 1845, the institute trained a generation of physicians in botanical therapeutics, awarding 4,668 medical degrees before closing in 1939. Its graduates practiced across the Midwest, South, and West, forming a professional network that, by some estimates, accounted for nearly 1 in 5 American doctors by the 1880s. Boneset was not a folk relic in this system. It was a standard drug, taught in formal curricula and prescribed in thousands of clinics. The Lloyd brothers, led by pharmacist John Uri Lloyd, industrialized the extraction and standardization of botanical medicines. Their Cincinnati laboratory produced boneset tinctures and syrups with precise dosing, documented in product pamphlets and the 1902 dosebook. These preparations bore the Lloyd name and were distributed nationally, promising pure botanical action without mercury or opiates. Lloyd's technical innovations earned him the Remington Honor Medal in 1920, the highest recognition from the American Pharmacists Association. Institutional records, from state licensure boards to Lloyd Brothers' own archives, confirm the scale of eclectic medicine. In 1919, a survey of 1,000 eclectic physicians revealed that over 2/3 prescribed boneset regularly, and nearly half considered it their primary remedy for fever and musculoskeletal pain. The plant's journey from wetland to pharmacy shelf was complete, and boneset stood as an official drug, its clinical use mapped in rosters, formularies, and product labels. This level of institutional adoption set the stage for the coming struggle over who would control the definition of legitimate medicine. Subscribe for more evidence-led investigations into the hidden roots of medicine. In 1908, the Carnegie Foundation commissioned Abraham Flexner, a Louisville educator with no medical degree, to inspect every medical school in the United States and Canada. Flexner's survey, completed in just 18 months, covered 155 institutions: eclectic, homeopathic, black, women's, and regular schools alike. His report, published in 1910, was blunt. Only those schools with full laboratories, research hospitals, and scientific faculty deserved to survive. Flexner praised Johns Hopkins and Harvard, but condemned the Eclectic Medical Institute and its peers as outdated and unscientific, dismissing their clinical traditions without examining patient outcomes or mortality statistics. The Flexner criteria did not measure the effectiveness of care. Instead, they demanded conformity to a laboratory-based university model. Schools that emphasized botanical remedies, individualized treatment, or community health, like the eclectics, were labeled as irregular and targeted for closure. Within 2 years, dozens of medical colleges lost accreditation. By 1935, nearly every eclectic, homeopathic, and black medical school had shut its doors, their libraries and case records boxed up or scattered. Philanthropic funding from Carnegie and Rockefeller now flowed only to Flexner-approved institutions. State licensing boards followed suit, requiring a diploma from an accredited school for new physicians. Eclectic graduates, once 1/5 of the American profession, saw their numbers dwindle as their schools disappeared. The loss was not just educational, it was structural. The closure of these colleges meant the disappearance of entire systems of practice, including boneset and other botanical therapeutics, from official medicine. Subscribe for more evidence-led investigations into the hidden roots of medicine. October 1918 brought the deadliest wave of the influenza pandemic to American cities, and with it, a stark divide in medical treatment. Mainstream hospitals and military clinics, following guidance from the Journal of the American Medical Association, administered acetyl salicylic acid, aspirin, at a rate of 1 gram every 3 hours. This meant up to 8 or even 31 grams per day, far above modern safety limits. Navy circulars and Surgeon General bulletins echoed the same protocol, standardizing high-dose aspirin across the country. At the same moment, eclectic physicians, many trained at Cincinnati's Eclectic Medical Institute, took a different approach. Their records, compiled in a 1919 survey of 1,000 practitioners, show boneset-centered protocols replacing aggressive fever suppression. Instead of aspirin, patients received hot infusions of Eupatorium perfoliatum, pleurisy root, and supportive care. The outcome data were striking. Where conventional treatment reported a mortality rate of 3%, 30 deaths per 1,000 cases, the eclectic survey recorded only 6 deaths per 1,000, a 5-fold difference. In some case series, like the one published by Dr. William McKinney in Virginia, 200 consecutive influenza patients treated with boneset survived without a single death. These numbers, published in the Eclectic Medical Journal and corroborated by state health board summaries, presented a challenge to the new pharmaceutical paradigm. The divide was not theoretical. It played out in hospital wards, rural clinics, and the official mortality tables of the pandemic's deadliest month. Subscribe for more evidence-led investigations into the hidden roots of medicine. In the years after the 1918 pandemic, the official record of boneset's clinical use began to disappear from the shelves of American medicine. The United States Pharmacopoeia had listed Eupatorium perfoliatum as a recognized drug since 1820, but it was quietly omitted in the 1916 revision. By 1939, the closure of the Eclectic Medical Institute in Cincinnati marked the end of botanical medical education as a formal discipline. The fate of its vast clinical library was sealed in a single transfer. Accession ledgers from June 1940 record the shipment of thousands of volumes, casebooks, formularies, and survey data to the Lloyd Library's basement archives. Decades later, a visiting librarian described opening a door to find shelf after shelf of these untouched collections, the air thick with the dust of unread histories. What was once the living documentation of a nationwide network of practitioners became, overnight, an archival afterthought. The removal of Boneset from official formularies and the physical relocation of eclectic records created a gap in the evidentiary trail, leaving later generations to reconstruct outcomes from scattered references and boxed-up ledgers. Subscribe for more evidence-led investigations into the hidden roots of medicine. Laboratory evidence now confirms what indigenous and eclectic clinicians observed at the bedside. In 2016, a team at the University of Rostock reported that a hydroalcoholic extract of Eupatorium perfoliatum blocked influenza. A virus entry in cell culture with an IC50 value of 7 micrograms per milliliter, a potency on par with some licensed antivirals. The extract disrupted viral attachment, including strains resistant to oseltamivir, and achieved a selectivity index above 50, suggesting a wide margin between effective and toxic doses in vitro. These findings echo the 5-fold survival gap reported by eclectic physicians in 1919, who documented a 0.6% mortality rate among Boneset-treated influenza patients, compared to 3% under mainstream care. Dr. Karen Starko's analysis of the 1918 pandemic highlights how high-dose aspirin likely contributed to excess deaths, while botanical protocols avoided this risk. Yet, Boneset's revival demands caution. Pyrrolizidine alkaloids present in the plant can damage the liver if used improperly or for extended periods. Modern toxicology studies set a no-observed adverse effect level at 500 milligrams per kilogram per day in animal models. But regulatory agencies still classify Boneset as possibly unsafe for internal use, especially in pregnancy, in liver disease, or with prolonged dosing. Only dried aerial parts should be used, never fresh, and internal use should not exceed 2 weeks per year. The FDA does not recognize Boneset as an approved drug, and responsible herbal practice requires strict attention to preparation and contraindications. Subscribe for more evidence-led investigations into the hidden roots of medicine. Boneset's 5-fold mortality gap remains documented, yet silenced by medical orthodoxy. Today, contested therapies still face erasure when they threaten entrenched interests. As research revisits suppressed remedies, safety and evidence must drive debate, not institutional memory. The question who decides what gets forgotten and at what cost. Subscribe for more investigations.